Hi, I'm Dr. Cooperstock from the University of Missouri. Unlike the previous two speakers, I don't see myself as illustrious or a rock star, but thank you for that original introduction. I am a pediatric infectious diseases person who got interested in this through the Streptococcal connection. And the purpose of my talk today will be just to not so much give all the details about streptococcal disease and its pathogenesis, but to highlight in my 10 minutes allotted by the organization today to at least point out some of the areas that I consider of sort of research interest and controversy perhaps regarding the relationship between group A strep and PANDAS. I do not have any disclosures, and I do disclose that I'm not sure how to advance the next slide. Oh, just do that. The easy way. So the 5 issues I'll address in my 10 minutes are to look a little bit at how close really is the relationship between group A strep and PANS. As you've heard, and I'm using PANS in the general sense to include PANDAS. As you've heard, not always is that so clear. Other times it seems very clear on a clinical level. Briefly mention something about the connection that Sue has already talked about in terms of the relationship between group A strep being worked out in its biological connection to this disorder in terms of molecular mimicry. The host is attacking something on group A strep that it shouldn't because it cross-reacts with host antigens, and what that may mean. What we know about that, put a whole hour lecture into 1 or 2 slides. Then we'll talk a little bit about our actual build. How good is a throat culture and other cultures to diagnose Streptococcus? And it seems very straightforward to those of us when we start out and you look into this in more detail, and it turns out that culture methods can be very misleading in both directions. Fourth, we'll talk about serology, and the same conclusions finally wind up. The antibody tests that we have to help us diagnose this disease can be very misleading and are problematic. And then lastly, we'll talk about something about where we're going to go with what we understand about group A strep strains themselves in terms of are there special strains that might be important in this disease, and for that we coined the term encephalotogenic strains, coined specifically for this purpose. So how close is this association really? Well, we know about this originally from Dr. Sweeto's first studies, which she talked about. The group at Rochester, not Tanya, but his Dr. Janet Murphy, I think it is, with Dr. Picicaro there, actually has one of the clearest published descriptions of this disorder, and it's because they came from a private practice. And Dr. Mike Picicaro has done numerous studies on streptococcal disease, and so this was a natural for him to follow this up. And they identified 12 cases from their private practice in which they had excellent prospective records right from the beginning, and were able to show that these 12 cases had strep at the time of the onset of their PANDAS symptoms. All of them improved with symptoms. Half of them had relapsed and got retreated and improved with symptoms, and all had improvements with antibiotics and did well. So this is one of the few grassroots kinds of studies that's available to us, and I think is going to be the wave of the future in terms of our really nailing these questions down about the relationship between strep and PANDAS. The data on this slide come from Dr. Murphy's talk 2 minutes ago, but I pulled out from her studies specifically the things that she did relating to Streptococcus. And so in this study from 2012, these were patients who had come to her after some time and had been an average of 3.5 years into their illness at the time of presentation, so that the diagnosis retrospectively of Streptococcus primarily depends, and correct me if I'm wrong, Tanya, on reviewing older records as much as possible. And so she was able to sort of separate 2 groups, one that clearly had PANDAS and another group that, as I read the paper, might really have had PANDAS, but were called not enough to meet the strict criteria. And so even those that didn't meet the strict criteria had antibodies at the level that was being screened. Even though it was statistically less, it was still a very large percentage of them had at least weak evidence for past streptococcal history based on the antibodies. And the same was true with the history of frequent strep, as she pointed out. So many of the patients had these histories of very frequent streptococcal infections, but even those that didn't fit the diagnosis so well commonly did as well. And most striking difference in her study was, and I thought was one of the most impressive parts, was that the group with truly defined PANDAS had remissions with antibiotics highly statistically significantly more than those in the second group. And I think you pointed out in the paper this was a preliminary kind of a descriptive study rather than a definitive study, but it's sort of where we're at this point and where we need to, it points out where we need to go with getting those definitive studies done in a prospective way. And then her most recent paper were patients that were studied much earlier rather in the course of their condition, and is without any prior screening for streptococcal disease, as she pointed out a minute ago. 58% of those had evidence of a group A strep trigger, so that could easily be an underestimate for the actual role. And again, as she pointed out, 72% had histories of frequent strep, and a lot of them had at least anti-DNase positive, although I think that the level of screening was done to be more inclusive. So if anything, that might have been, I thought, a little bit overestimate. But then again, as I'm going to point out in a second, serologies ain't all that good. Another way of approaching this is to look at what's called administrative studies, in which it's possible to study the records of huge numbers of people enrolled in care programs and be able to get a bird's eye view. And two studies have shown that if you pick out patients who have had a history of tics alone, OCD alone, or a combination of OCD and tics, it turns that those that have that combination, which probably isn't necessarily PANS, but at least it puts it in the PANDAS patients will be in that group. PANS patients will be in that group. The odds ratio for there being a prior streptococcal infection documented in these records, and you can do this with these huge studies, showed an odds ratio of about 1.5. So statistical evidence, even on these broad view studies, also tends to implicate strep. So there's little doubt about the connection between streptococcus and this disease, but the details are what we need to find out next. So for that, I conclude where we stand with this at this point is that more prospective studies are needed, and now that PANDAS and PANS has become more and more recognized thanks to meetings like this one, and as Sue talked about, a better and better understanding of this disease, it becomes more recognized earlier and earlier. That will give us and the research side a pool of patients to study right off the bat and be able to start some of the studies that need to be done to really pin this down. Am I out of time? Sue's looking at her watch. She says, go fast. So the idea of molecular mimicry, Sue's already talked about, and I'll just try to say this briefly, is that one of the key targets of this antigen is the group A strep carbohydrate itself, in which there's which is made of rhamnose N-acetylglucosamine, which we call GLICNAC. And the GLICNAC, Dr. Cunningham has pointed out to us so clearly, seems to be the key molecule in this autoimmune cross-reactive response, and she's gone a long way towards showing that. Including this panel of 4 antibodies, specific brain antibodies, to cross-react with the streptococcal GLICNAC. So this is true. She was able to pull out monoclones, which is a sine qua non for these kinds of studies for Sydenham's, and show that they also did these things, and we're looking forward to studies like that in PANDAS as well. And then the animal models, Sue has already talked about. So we still, I think, need to clarify exactly what the target neural antigens are much more clearly. What we've done so far with Dr. Cunningham's help is show that these neural antibodies are demonstrable, but in terms of where's the real target that's causing the real problems, and which antibody fits with which symptom, still is a major question that has to be worked out, so that defining the exact epitopes and the tertiary structures of these molecules remains to be done. If you can imagine, if this is the molecule that has the reactive site on it, and by monoclonal antibody studies, basically what Cunningham teaches us is that one antibody might react to a molecule this way, and one might react this way or this way. So even though you have an antibody to a specific molecule, it may do so in a multitude of different ways depending on its specificity. And this is the fine detail that needs to be worked out. So detection of group A strep. It's easy to get a false negatives throat swab if you just don't do the technique vigorously enough. So they can miss strep for that reason. We recently did a review of the literature in which, this is interesting, we were able to find 11 studies that were done at tonsillectomy in which this tonsil was swabbed before the surgery, and then the tonsil, the core of the tonsil was cultured after it was removed. And by doing that, the studies were universally showed that there were strep hiding in the tonsils that were missed by strep swabs. And the median number for the studies overall was about 30% of strep were being missed by swabs. And you can imagine the swab you do before surgery is probably much more effective than the one you're going to do in the clinic setting. We also know that group A strep can survive intraepithelial cell, it can survive intramacrophage, and it forms these biofilms within the tonsils, all of which make it more persistent, which in persistence is certainly one of the keys towards inducing autoimmunity, and also adds to its difficulty of us detecting it. So there are many times when people have shown group A strep persistence in the antibody, I should say persistence in spite of negative throat cultures, and maybe that's the reason why the bugs are really there, but they're hiding a whole other area that still needs to be worked out in more detail. So the other side of it is the false positives. If someone has a strep in their throat, at least the current thinking on it is that these may be carrier states, and that's defined by having the strep in your throat and having no antibodies. Yet we already know that the antibodies are missing a lot, and what's really going on in the carrier state is not really all that clear and still also needs to be worked out. So for getting a proper diagnosis, it'd be nice to have more sensitive assays for the recognition of strep, and there are PCR and other techniques that are improving that somewhat, but I think we'll never be able to get to the core of the tonsils in a clinical setting. But better antibody testing certainly is on the list of things that need to happen, and that is going on in research labs in the country now. So it may be possible to do more than just our 2 antibody tests, which are so inadequate, and maybe have a panel of 3 or 4 or 6 or 7 that will really tell us more about what the streptococcal history is. So serology, as mentioned, has been bad. And I'll flip through this quickly, only to say that there are a lot of false positives and false negatives with serology as well. Single titers, which we often depend on in these retrospective studies to tell us something, really don't tell us a lot because there's so much false positivity in that kids are exposed to strep. The average child gets more than 1 streptococcal infection per year in school. And so that it makes a background that makes it hard to pick out which ones were incidentally seem to have strep and which ones really had strep that were causing our problem. So for this, better antibody assays are needed. We now know that there are over 20 virulence factors in streptococci, and so antibodies to these various virulence factors could potentially be studied. One of them, called anti-C5a peptidase, is one of the more promising ones. It was worked out by our friends at Minnesota, and there are several others that look very possible, and there are many other ways now with modern molecular biology to approach this whole question of improving the serology as a diagnostic aid for a recognition of strep. And for those of us in the PANDAS world, this is going to potentially be very, very helpful. There's much more to be known about the connections of these antibodies and antibody subtypes and this disease. Now we know that group A strep not only has the rheumatic fever and post-streptococcal nephritis, but there are numerous other post-infectious syndromes that have been attributed to strep, and that's not true of the many other respiratory other gram-positive pathogens, including respiratory pathogens like pneumococcus, pathogens like Staph aureus, and other gram-positives have not been connected to these syndromes. There's something about Streptococcus we think that makes it tend to induce autoimmune diseases. And one of those characteristics may be its superantigens. There are 5 different strep superantigens known. It infers a property of the strep of being able to stimulate immune responses non-specifically, turn on T cells and B cells. And clearly that would be one way, at least theoretically, to induce an autoimmune process, and that's an area for a promising area for further research as well. So for this, we need strep strains that are derived from patients diagnosed early. They are very hard to come by right now, and so as we get to earlier and earlier diagnosis, with collaboration from primary care doctors, we'll finally get some strains from these patients that clearly are within the first week or two of onset, and the technology to study these organisms in detail and figure out if there's something special about them is waiting to be applied to these strains. So that's the bottleneck now, is simply getting the strains. So in summary, how important is group A strep to PANDAS? Possibly much less than we know, but more likely much more than we know or think we know at the present time. And so further science can help distinguish this. I personally believe that the number may be as high as nearing 100%. Even those that seem to be triggered by some other infection may really are just activating a streptococcal process, and the development of these techniques I'm talking about will help clarify that. I'm hopeful. So for diagnosis, we need better detection, we need better serology. For number 4, we certainly need to have more PANDAS-associated strep strains. And finally, it would be nice to have a good animal model for streptococcal pharyngitis in which to do these studies, and even that seems to be on the horizon. Thank you very much. How much did I exceed?